Good afternoon, everyone that decided to join us today. Really appreciate you hopping on the phone today so we can hear from our esteemed panelists. So, as Jarrett said, my name is Daren Smith. I am the VP of ASC Solutions here at Surgical Information Systems. I'll be the MC for today's discussion. I have three very good administrators on the panel with me that are going to be fielding my ever increasingly questionable questions. And so I thought we'd start off with a quick introduction of each one of those people. I'm going to start with Jeff. Just give us a little background of what your role is and tell us a little bit about your center so people can make that connection.
Okay. My name is Jeff Flynn. I'm the Chief Operating Officer and Administrator of Gramercy Surgery Centers in New York. We have one center located in Manhattan with 4 operating rooms and one center located in Queens with 4 operating rooms. We're multi-specialty across the board with 9 specialties. And we opened their first center in 2002, the current center in 2006, and we opened our satellite center in 2015. I'm also Vice President of the New York State Association of Ambulatory Surgery Centers also.
Fantastic. Thank you so much, Jeff. Colleen, you want to go next?
Sure. My name is Colleen Ramirez. I'm the Chief Administration Officer for Bone and Joint Surgery Center of Novi. I am servicing a center that's been open for almost 17 years now. We have 6 operating rooms, and we are a hospital and physician-owned facility. We do just roughly 6,000 cases, mostly all orthopedics, so a lot of sports medicine, total joints, podiatry, pain, spine, but rotating all through the orthopedic spectrum. And so, yeah, I'm really happy to be here today. Thank you.
Fantastic. And Shellie.
Hello, my name is Shellie Rivera. I have been a nurse for a little bit over 12 years. I joined the St. Mark's team that's located in Southwest Florida. It's an ophthalmology ASC. First ophthalmology ASC I've ever worked for. I initially started here working in pre-op and PACU, and then later transitioned into the operating room, eventually to a management role, and then which ultimately led me to my current position of the administrator. We are a high volume, fast-paced surgery center. We have 4 operating rooms, and we run 4 days a week, Monday through Thursday. We perform somewhere close to 10,000 cases annually. That include, cataracts, retina, oculoplastics, and corneal transplants. And we are 100% physician-owned.
So after those bios, can you guys see why we picked these 3 people? Very dynamic group of people. We have some that are partially physician-owned, wholly physician-owned, partnerships with hospitals. We've got high volume centers. We've got very multi-specialty. We've got single specialty, and all 3 of these centers are extremely successful, and we attribute a lot of that to their leadership. So that's why we brought these 3 people on to talk to us today. And we're going to start things off with kind of a general question about the ASC industry itself. And so we'll start there, and then we'll drill down a little bit to your individual centers. But to start off, how would you describe the current state of just the ASC industry itself? And we'll probably go to the person that has the most ASC industry experience. Jeff, why don't you start us off with that one?
I think it's a very exciting time for ASC industry right now, because it really is our time, because as unsustainable healthcare costs, we're definitely the alternative that insurance companies are now recognizing, that hospitals are working with us, recognizing that also, that we can actually provide access of care in different areas so much more efficiently, and leaving the hospitals open for the more emergent and high level things that need to be done there. I think in the next several years, you're going to see a transformation of so many more surgery centers, but I do think we are really the vehicle of the transition of the whole healthcare industry to be a much more efficient and much more across the board able to give access regardless of the ability of and circumstance of the different patients.
Hmm. We've seen that slow over the last probably decade where people are finally realizing, hey, the first $5,000 of this healthcare stuff has to come out of my own pocket. Where can I get this done that's not going to break the bank? Because that's basically one visit to the hospital, right?
Mhm.
That's going to hit your deductible. Where can I go to be more efficient with my money? So
Yeah.
great points there, Jeff. Shellie, you want to follow up with that? Anything you want to add to that?
Yeah, as surgery centers evolve with improved technology and expanded procedures, I mean, they offer patients a high quality, lower cost alternative to the hospitals, like Jeff said. The hospitals are higher cost, and ASCs are, a great and safe alternative to that. So ASCs are definitely growing in popularity. So.
Mm-hmm. Colleen?
I think too, just to flip it over a little bit, and we focus so much on patients, and we do have it's a much higher patient satisfaction for both care and service in the ASC, hands down. But I also think that a huge piece of what makes ASCs great and how the industry has changed is watching the transformation from staff that worked in hospitals to come and work at ASCs kind of through COVID, and how much their reaction is. So I love the fact that we can not only provide such great service for the patients, but we also have a great employment option for our healthcare providers out there.
Mm-hmm. Yeah, that's a great point. We're going to talk a little bit about staffing, and I have some questions wrapped and revolved around that as well. So we'll tap into that in a little bit. But I wanted to follow that up with, we see those trends right now in the healthcare industry, in the ASC industry, the growth and the movement of cases into the ASCs. Has that changed your center? I mean, how has your center adapted to the changes that have been presented to the ASC industry? And we'll go backwards this time. We'll start with Colleen on this one.
Yeah, I think that adapting to the changes. So one of the things that we've done is I have a really robust, we call it PST at our center, but a pre-surgical screening department. The nurses some of them have been with us for 17 years, but we've really greatly defined some of the roles and some of with the higher acuity cases, we've really been looking at taking, I guess you'd call it, sicker patients or patients with higher comorbidities. We recently, over the last 5 years, we eliminated our BMI limit. So that was something that, it raised a lot of eyebrows and everything, but we do it very safely. We look at all those procedures and, evaluate risk and everything, but ultimately that access gaining is to take a look at all patients now, and that's made a huge difference in the care we can provide. So.
Oh, fantastic. Jeff, what changes have you seen recently that made you need to change things at your ASCs?
We just implemented, we've had a bariatric program since 2013, but we actually just implemented where we're now doing the laparoscopic sleeve in centers. So therefore we have a very talented surgeon. It's actually the president of the American Metabolic and Bariatric Association, is located here in New York. And she actually does surgery with us. And she did the first bariatric laparoscopic sleeves here. In addition to the fact, we're seeing the issue of that because we did, to Colleen's point with BMIs, the average surgery center is 30. It's always been traditionally 38 to 40, and they cut the BMI off. So as we started doing bariatric, we were able to open that up to so many others because we have all the airway equipment. We do the anesthesia does the airway evaluations ahead of time to make sure that the patient is appropriate for the setting. But like we're now doing BMIs straight across the board up to 50 without a problem. And that just opens up access to so many more patients because, especially as the doctor says, well, I only do surgery at the hospital once a month and this is my surgery schedule. I do it once a week at the surgery center. But anybody who was a 42 BMI, you were on that longer list and you were waiting, and now they're able to go forward through it. And again, we're able to do higher and sicker patients just from technology. I think as it's evolved. There's a story specifically, if we go back, 35 years ago, it was much longer than that, probably 40 years ago, it was 2 weeks in the hospital with sandbags on your head, on the sides of your head for a cataract. You're in and out of the OR in 9 minutes now, and you're not even asleep. I mean, that's where technology has gone forward, and we've been able to deliver that to the general population.
Fantastic. Shellie, how has your surgery center adapted to these changes in the ASC industry?
Hey, Daren, I think we lost Shellie's connection. I'm going to try to work with her to get her back on.
Okay, sounds good. Thank you very much. So we'll move on to one of the parts, the pieces of the puzzle that we always talk about in these conversations, and that's staffing. Staffing, it has increasingly become a bigger challenge in the ASC industry. I, barely had to put an ad in the paper when I was running my ASC, and I'd have hundreds of people applying for those positions. Well, those positions are getting a little harder to fill. So we are interested in hearing from Colleen and Jeff. What changes have you had to make at your surgery centers to retain your staff and recruit new staff into the surgery center? Why don't we start with Colleen? We'll end with Jeff.
Okay, I'll try not to take up too much time with this because it's my favorite topic.
I know. Yeah.
I do think that at least specifically at my center, some of the things, and I don't know that there's so much changes as their focuses. I've really shifted my focus to look at that, the value in retention. I think that's it all obviously very much resurfaced through COVID as well. But I really care deeply about my staff, and I know most administrators do. I go a little extra mile with them on so many levels to make sure that they're supported by their direct supervisor, that they have the schedule they want. I mean, we've changed a lot where we've moved on to a 4-day full-time position, allowing them to be able to do that. That was a great satisfier. Of course, we are continually and always looking at pay. And one of the things we've done over the last couple of years is to just try to establish benchmarks in our community and not necessarily look at just what our ASCs paying. We've looked at what are all healthcare institutions paying. We used to be able to sit back and say, hey, we're the, 9 to 5, Monday through Friday, no weekends, no call. But employees, they want more. So we've done things such as increasing our 401k match. We've raised it up to 6%, and that all of my employees take part in that. That was a very big bump and bonus for them. We've changed a little bit of our pay scale. I don't like having a cap on a pay scale. Maybe I lived with that forever in the hospital, and I use that as a retention and a recruitment tool. So benefits are a huge thing for people. For some, they don't care. I think you have to offer, I love offering an annual bonus. We have, I think the center's been open 17 years, so they've been giving one out, I think 16 of those 17 years. We budget for that. And overall, though, I think hourly rates are very important to be very uberly focused on continuously, and providing those reviews and making sure that you're looking at staff growth, development. Can you cross-train someone? Can you take, someone? We've opened up the door to new grads and train them in the operating room as circulators. We've looked at a lot of different components. I have promoted a lot of different people. I have a person who used to be my turnover tech is now my business office manager. So, while she was in school, she learned many different traits, and, she's a fantastic asset to our center. So recruitment, retention, yes, but be creative, have lunches sporadically, really budget for, I guess spoiling to some extent your employees. I think it goes beyond being a great manager and a supportive one with, an open door policy, but to also pay attention to them, be active in their lives, and also make sure that you're continually asking them their needs. Do you need anything in your department? Do you, and just recognize hearing that. And then, of course, the number one thing is to make sure that you are tapping into your talent. There are so many talented people out there, and a lot of, employers don't always sit at round tables or sit down with them and ask them to, give what would they do? How would they do it better? And I have just, my facility has grown substantially, and we've done such higher acuity cases, and there's nothing more productive than to sit down with your department or look at a group of scrub techs or nurses and really take the time for those meetings and really scratch, deep in the surface, because sometimes people are shy and they don't really want to speak up about how they would do something different. But you need to constantly refocus operations and look to just become more and more efficient. And then, of course, don't forget to ask your surgeons and find out, how they would, how they are doing and everything. And that just keeps this nice, circle going well. So.
Yeah, that was one of the factors that drove me to the surgery center industry. Is in the hospital, if I wanted to reward someone who was an employee, I had to follow a scale. I couldn't take my highest performer and pay them the most amount of money. And if I wanted to, I had to go through 3 or 4 different committees to be able to do that. In the surgery center, much more agile. I could sit around with a group of people. They could make suggestions, and we could actually act on those suggestions. And that was one of the things that not only drove me to the ASC industry, but made me stay in the ASC industry, is that agility and the ability to change. And I have to let everybody know too, when we were preparing for this panel discussion, we were going over some of these questions. I posed this question, and Colleen said, do you think anybody'd be offended if I just told them they got to pay them a lot of money? And so I thought that's how you were going to open with this. But no, I like your much more detailed explanation. That works just as well.
Yes, pay them a lot
Jeff,
of
money. Yeah, pay them a lot of money. That's right. Jeff, it's got to be a very dynamic industry in New York. Lots and lots of competition there for staff. How have you guys set yourselves apart and be able to retain and recruit staff?
I think you got to look at it from different ways. Like during COVID, obviously, and then getting out of COVID, the hospitals were getting so much money. They were offering these bonuses that people were just jumping that, like nurses were starting with a $10,000 sign-in bonus, and the requirement was to stay 6 months to attain and keep it. So we were losing nurses in that situation, losing nurses to other centers too. So you're obviously constantly looking at, as Colleen referred to, you got to be looking at that hourly wage very clearly and seeing where you fall into it. And I think in the past, we ran into the mistake of when we did look at that, we looked at it and then we didn't think about it for 2 or 3 years. I'm telling you, you're thinking about it on a monthly basis now and focusing on that. The other factor is just getting people. The clinical staff is one factor, but like even just your administrative staff. And one of the things clearly, like we have a similar success story. Our business office manager, as she went to school, started out as a receptionist. So she's now business office manager. I think 6 years ago, she was a receptionist. So in time, looking at people and giving a pathway that they can develop. And that's very important to make sure that they can develop, because then they were able to go out and do that. I've had some administrative people become central sterile techs. I've had others have gone to the certified tech schools to actually become surgical techs, because as time went on, they went to want to do that and further develop. But I think we also have to look at outsourcing in a number of situations where you just can't do it. And like, for instance, a big aspect is in billing. Keeping a billing staff today, especially here in New York City, is just, it's, I just gave up at that point. And I just knew that, that's not where my efforts in staffing need to happen. So I think you've got to look at different models in outsourcing where you can. That doesn't matter, and focus your attention on the areas that really do matter. Backing your nurses is the most 100% thing to do. I always started out, I'm the son of a nurse of 52 years. I feel this metaphoric smack on the back of my head if I ever go against a nurse. So that is always in my mind. And But that's where, to make sure the nurses know they're part of the team and decision making. A nurse can actually, the RN, circulating RN nurse at my centers can actually call the case off. She does have that authority. She understands the burden of that responsibility, but she's also protecting the center's interests and she's protecting the patient's interests at that point, because that's what they're there to be, as the patient's advocate.
Fantastic. Thank you so much, Jeff. I think we have Shellie back. Shellie, we were just talking about staffing, recruitment, and retention. So what methods or functions have you guys been able to pull forward to retain and recruit staff?
Going back to what Colleen and Jeff said, after COVID, we had a lot of the nurses from the hospital actually come over to the surgery center, because even though they were offering a lot of money, what they were doing over there was not sustainable. So we did get a lot of nurses that wanted to leave the hospital and come over to an ASC. So, again, benefits is a huge thing. We review our benefits annually, make sure the insurance costs, if we can even lower that. We look at, reviews of performance reviews. We look at the pay. We try to, stay competitive, obviously, in the area. We do get bonuses. And like they said, talking to your staff is the number one thing. They just want to feel, heard. We do daily huddles with our staff. We talk about the day. That gives them an opportunity to kind of give their input on things. So, just being there for their staff. We do one-on-ones a lot. Me and the OR manager will sit with each employee individually and just ask them, how their day is going, what they look for in their job, and just try to meet their needs. So, all those things put together has helped us retain our employees here, and they're very happy.
Fantastic. Yeah, most surgery center employees, when I have the luxury of visiting hundreds of surgery centers every year, and they're by far the happiest employees I've ever come across. So one of the questions that did come in through the chat, Colleen, Jeff, do either one of you have 23-hour stay?
Nope.
Now,
okay, I didn't think so.
It's a concept that we try to do, but New York State is not really keen on that. So therefore, we've just kind of gone with them that we just don't do it.
Yeah, I think that's what a lot of people, their biggest staffing challenge has been those 23-hour stays. So I think that's why that question came in. But since we don't have any experience with there, we'll move on to one of those things that can actually help our staffing. And we can't have a discussion with surgical information systems without talking about automation. So one of the ways that we can reduce that staffing burden is with automation. And I know all three of our panelists today have used some sort of automation to help them with their processes and create more one-on-one nursing time with their patients. So I wanted to have them talk a little bit about that. Colleen, what are you guys using as far as automation to help have that interaction with the patient and reduce the burden on your nursing staff and administrative staff?
Well, I think over the last few years, we have really relied heavily on text messaging, and we have email, of course, as well. But we decided recently to really take a look at, is there too much information or too many texts being sent to patients? But overall, our automation, we're heavy on the pre-op side and maybe could benefit from a little more intricacies in the post-op automation. But I'll give you a couple examples that we were pretty excited about. With the larger increase of patients taking those GLP-1 type injection drugs, we had created a policy that had said we want you to be, at least 7 days or more off of them before surgery. So we made, if a patient comes in and has that medication listed, we have flagged them, and we then send an automated text out 8 days prior to remind them not to take that dose. That has been a great asset for us, and it's all automated, so that's fantastic. One of our backbones to automation has been to send out a text the night before to remind them to be NPO. Also to let them know that their driver, they must be accompanied by a driver, they have to stay on campus during the procedure, all of that. And then we've been a little more granular and have had some CPT driven like coded pathways in automation. So we do a lot of total joints, and so we began with that, which is really, it's nice. And then we also have an automated text that goes out to remind them to complete their health history online if it hasn't been tagged in the system. Again, very nice. Of course, we all want the patient to fill it out instead of having a nurse on the phone for an hour going through that and entering that. That is a huge time saver. We do other little things like, traffic updates, and if there's a lot of construction going on, we'll send that out the night before. So I think we're more heavy on the preoperative side. We also do different joint automation, or for our total joint patients, we do automations with joint education. Try to hit them with different avenues of education so they're fully aware of what to expect when they come in. And even how to prepare their homes. And so when we looked at it post-operatively, one of the things that we changed recently, I hope can be a help to some, is to automate a text to remind them to read their discharge instructions. I know that seems silly, but a lot of patients will, or the driver will just kind of chuck it in the backseat of the car and they forget about them. And so we purchased these bright pink folders and put an orange sticker that says discharge instruction on it. It has made there's a lot more compliance to discharge instructions now. We did a little quality study on it. But yeah, it's that piece of it is fantastic. We feel patients are reacting to that positively. We haven't had anyone say, there's too many texts. I mean, we worry about it to some extent, but we've never had the complaint, so that's nice. There's also ways to, automate. We're looking into automating some videos for certain procedures, like physical therapy videos and such. So I think we can grow more in our automations. I'm just hoping patients tolerate them well and don't get irritated by them. And then of course there's always looking at post-operative surveys, and there's a lot of ways you can be creative with it, but those are just a handful of things that we're doing. And I think it really helps reduce phone calls, and it just really helps the patient overall. And so we're hoping they like it. We haven't had bad response rates. So.
Yeah, I've seen quite a few articles talking about notification fatigue.
Yes.
And all the notifications, because my dog groomer is sending me text messages, and my dentist sends me text messages, and Brooks Brothers is sending me text messages. When does it all end? And they're finding that the last study I read said that they're finding that consumers are being very forthright with logging off, with not associating them or unsubscribing from the ones that they don't care about. And part of the federal rules about unsubscribing and things like that, I think, has helped them distill the important messages that they want to get. And so, yeah, I think that's an incredibly important point to point out to our full audience there, that be aware of that notification fatigue and be very thoughtful, as Colleen has, about what you're sending out as far as patient communications. I know Jeff and his center has done a lot of work and a lot of automation on the business side of things. So I wanted to give Jeff an opportunity to talk a little bit about the automation that they've brought into their business office.
We actually, obviously, facing staffing issues and outsourcing different things, what we did is we worked and we actually are integrated where our most common procedure that needs pre-certification is cataracts. And they don't need it with Medicare, but all the Medicare Advantage plans they do. So we actually automated and worked with a company that we actually have a bot do the actual pre-certification for us, and it has an effective rate of about 94% as it goes through, which is pretty significantly high, just in the aspect of somebody not being on the phone, and the number of things that they can get done right away. It just really just goes through, and it's an automated call. They know what the questions that are going to be asked and the prompts, and they've kind of set it up to each insurance company. And we're doing it now. Actually, one insurance company is actually working with us on it because they like it on their end too. We really haven't told the other ones we're doing it to them, to be honest with you, but I guess we're doing it today. But that's actually been effective as we've done that to just try to first start things in. We've also done a lot with, we have videos specifically to whatever the issue is, your preoperative experience, your preoperative prep, explaining your copay and deductible and what that is. We actually have videos that we actually do send out to the patients where it's ones that we've had. It's an actor kind of come in and just say at Gramercy Surgery Center, here's exactly, but it's explaining the entire process to them. And we're getting a lot of positive feedback to that. And to kind of, as Colleen touched on, patient satisfaction, we're about to fall into the situation where patient satisfaction is going to be a condition of coverage soon. And it's where I think we will shine. And I think that's where we need to pay attention more in automation of how we can still shine. Don't know how the hospitals are going to do that. So that's going to be an interesting situation.
Mm-hmm. Shellie, are you guys using any automation? I know you guys are a very high volume center. Are you guys doing some automated patient interactions or anything?
Yeah, we are. We are mostly right now for the business office, I would say. Our center, has seen a significant improvement in pre-collections. And by utilizing the patient invoicing and estimate tools through SES, resulting in a 17% increase in average collections per case. And we also seen a decrease of 6.5% of days in AR since implementing this in SES. So the integration of Waystar with SIS has been, instrumental, in monitoring payments and claim processing. We have an amazing RCM team. So our pre-collections is significantly increased. On the clinical side, like Colleen said, we used to use an automated system to send patient text messages and give them their pre-op instructions, and things like that. However, we live in Southwest Florida, so our demographic is, elderly patients. So we were getting a lot of complaints about the messages, and, it was taking them too long to go onto the site to fill out their paperwork. So we kind of simplified that a little bit, and we send the offices a medical history questionnaire that the patient can just fill out at home and bring with them the day of surgery. So, that helps them, not having to do all that paperwork online. With the OAS CHAP that's coming up, the company that we decided to go with does have an option where they can do our post-operative phone calls for us. So I think we're going to look into doing that as well as the patient satisfaction survey. So that will help on the clinical side as well.
I'm glad you brought that up because that was one of the subjects that we had on our list here of things that we wanted to talk about as we started seeing that increase in regulatory burden on the surgery centers. The OAS caps is something we've been kicking this can down the road for years. Is it going to happen this year? I think it actually is going to happen this year. So Shellie, tell us a bit about what process did you use to choose your OAS caps provider? And you mentioned a little bit about it already. What all are you having them do for you?
So starting in September, we partnered with a CMS approved vendor. It's JL Morgan. To conduct our patient satisfaction surveys. So we met with 3 vendors that came highly recommended from a forum for ASC managers and administrators that I'm a member of. It's through a social media platform. So we, contacted the 3 vendors and we met with them and we ended up choosing JL Morgan. So, these surveys aim to incentivize improvements in, care quality and provide valuable data from patients' point of view. So it's great. They cover various aspects such as, preparation for surgeries, the check-in process, the facility cleanliness, and staff communication. So the feedback gathered will be used to enhance the overall patient experience at our center and identify strengths and weaknesses in patients' experiences, and assess the impact of our, interventions on improving in those areas. So we're very excited to start this process next week, actually.
Fantastic. Colleen or Jeff, is this data you guys are actually going to use, or is this just more regulation that's sitting on top of regulation?
I think we're gonna. Oh, sorry, Jeff. Go ahead.
No. Go ahead, Colleen.
I'm actually Shellie. We also chose JL Morgan, and very excited. Very seamless, easy process. I had a little advantage of I'm on the ASCA education committee, and so when I polled everyone there and asked, a lot of them had a really great reaction to utilizing that company. So we're looking forward to it. But I'm really excited for it. I don't feel it's a huge, it's going to be a huge burden, even with, the software that we're using currently to export the data out. I think it's going to be just another step in our process, but I am excited to see the data. It's questions we don't all, currently ask. And I think all of us administrators, if I've met one, I've met 1,000, and everyone wants to do well. They want their centers to be great centers of excellence. And I think it's going to be interesting to find out. We might have to remodel our break room, our waiting room. You never know what you'll get from that. And I'm excited for it. I know it's another regulation. I get it, but I think it's one that it's actually something I think we should be excited about hearing the feedback from patients.
I agree.
Excellent. Jeff?
No, I think we're definitely going to be using them because I think it establishes patterns that you'll find out, and it's like looking into particular things. There's been sometimes we've already started using the program, but as to get ready, what we've actually noticed in certain circumstances that in 3 or 4 of the different complaints, we actually tracked it right back down to it's a matter of proper staff training of a particular individual was not actually thoroughly giving the information correctly. And so, we're getting the same complaint each time, and then it turns out that they weren't doing it. And, going through the processes, we had to train that person. This is what you're supposed to do. And, we haven't seen that complaint ever since. So I think just in that short period of time, seeing that, I think we're going to see that across the board in just different things that you can go back and, as Colleen said, it might be redoing your lobby. It might be telling your maintenance staff, check that bathroom every 30 minutes. It might be whatever it is, just to make sure that it's all set in play. But I think it's definitely going to be extremely helpful.
And I think just one more quick point to make. I think, for some of us that are maybe haven't signed with a vendor yet or are still kind of dragging our feet on it, it's important to obviously get a vendor, get going. It's almost September, so but I do think that if you are contracted with a vendor and you're making all the efforts, some of the biggest fears of this came out with trying to achieve those 200 surveys and really looking at that. And I think that we're going to see some leniency from Medicare. I do. I think they're going to see that you've engaged with a vendor, you're doing the work. I really don't see them pulling back money from us or penalizing us if those things are in place. So just keep that in mind. With anything new, there's always, some hiccups through it. But I think, and if you don't like your vendor, and it's becoming very complicated to get the data to them and, make sure you're looking at your contracts and not signing 5 years right out of the gate or anything. But look at that again over a short period of time and make sure you're talking to them so that the process is smooth. It should be easy. It really should be.
Mm-hmm. Yeah, we've talked about some of those things that contribute to that patient satisfaction, but and having that avenue in which they can report those things. And we talked a little bit about staffing as well, but we left out one of the big pieces of staffing, and that's anesthesia. So we have seen report after report after report saying, we're going to have a catastrophic shortage of anesthesia going forward. And we're starting to see some of that now. You look on Becker's, you look on ASCA Focus, you look wherever you look, there are these stories about the anesthesia shortage. So I would be interested in understanding what you guys use, what model you use for anesthesia, and if you've had any anesthesia staffing challenges.
Definitely we've had. I got to tell you, it started in New York. It was interesting. It was a year ago. It was at the ASCA fly-in a year ago in February. The state president, who's at a Syracuse center, was telling me all these problems about anesthesia suddenly, that he wasn't getting the coverage, that groups were coming in, they were demanding more money, they were demanding stipends for the first time, they were coming and they couldn't keep staff. And I just said that, I was like amazed by that. And I said, this really is probably going to be an issue. It hit New York City by June. And I didn't think it was going to hit that quickly, but it really hit it quickly. We have a model, our staffing model, we actually use a large group. We actually use the Optum group to do our anesthesia, but separately we have to pay an additional stipend now because, if you're serving the types of patients you're serving, because of the backwards payments that Medicare and Medicaid give to anesthesia per unit is crazy. Mm-hmm. If you have a good patient mix and different things, you can do things with that. But we had to hire a per diems also, because if we want to use all of our rooms, we have to staff per diems for those rooms, and then we're responsible for those rooms directly. If there's any overtime, because cases have gone past the time, we actually have to cover the overtime now. And, that was unheard of 5 years ago. It was a great contract for them walking in. And then as time went on, and because of the shortage of anesthesiologists, they're demanding more and more. And the salary of a nurse anesthetist has gone up. It's literally gone up over 50% in the last 3 years. And I've just never seen an industry thing going up that quickly. Getting a new anesthesiologist in New York right now, you're talking at least between 600,000 and 700,000.
Wow. Shellie, I know you guys used your contracted service as well. Have you guys had any trouble with anesthesia?
Well, I think we can all agree that, providing anesthesia services is probably one of the costliest aspects of running, or operating an ASC. And it's likely to become even more expensive due to the continuing shortage of providers and increasing salary demand. So, utilizing this, we ensure that we manage the block schedule so we can condense it as much as possible. We're constantly monitoring, the schedule to see how many cases a surgeon has, to see if, they're filling up their block. If they're not filling the block, we maybe will ask that surgeon to move those cases to a different day, or maybe follow a surgeon, just to help reduce the need for another CRNA. That really helps us a lot. Our anesthesia model is like a supervision model that takes, the collaborative team approach that consists of one anesthesiologist and then a group of CRNAs. But we haven't really right now, because we're in the summer season, we haven't really seen an issue with getting coverage for CRNA. But definitely in season, I could definitely see that being a problem for us. But again, just managing the schedule has really helped us, eliminate the need for the CRNA. So.
Okay. Colleen, what anesthesia coverage method are you guys using, and have you seen anything that has thrown a wrench in the things?
Yeah, absolutely. I have the almost exact same model as Shellie, the anesthesiologist and CRNA supervision model. I am really lucky. I know a lot of centers can't particularly speak of this, but I have fast surgeons, and a lot of them bounce rooms, and their schedulers. We work really close with their schedulers. I've spent a lot of time educating schedulers. My scheduler educates the scheduler to ensure that condensed schedule. And I think over the years of consistently having those discussions, my scheduler will seek out over the next 2 to 3 weeks and consistently send an email, what cases are you bringing in? Remember, we'll have to change this block and shift this to a different time, or you'll have to follow. But and then we also work closely with our anesthesia director, on site, and he can log in remotely too, which is nice, and really condense is the name of the game. But if you have physician owners out there, I highly recommend that you have these discussions about how this is really, affecting the bottom line and your budget. Because the more stipends you pay, obviously, I'd rather not pay any. So, and that should be everyone's goal as we can. But I'm very thoughtful to my my anesthesia company, the vendor, and working with them daily. I mean, daily, and making sure that the next day and getting their feedback. I mean, sometimes they can be creative with their schedule as well, and help us really condense. And so condense is the name of the game. Get your physician, to your physicians to buy in and to really help with that. And I've seen that really help overall our operations from our payroll expenses, when you do things like that. So pay close attention to that and educate your scheduler to educate the schedulers. Fill a block before you open another one. Sometimes the schedulers will offer any day of the week. You want to come Friday or 2 day, whatever. And so I think it's important to make sure that they understand to fill that block first before they offer another.
Right.
And just to add to what Colleen said also, with our anesthesia provider, they require a 2-week cancellation notice to cancel CRNA. Otherwise, they're paid for whatever their contracted, hours are, 6 to 8 hours. So again, going back to managing that schedule, we're looking, 3 weeks out. And if if we look and see that the surgeon doesn't have many patients, we'll, pick up the phone, call them and say, hey, this is how many cases we need to know. If you're going to fill this block, if not, we're going to have to move you and you're going to have to follow somebody or, move to a different day. So managing the schedule is super, super important to help reduce that cost.
So what I'm hearing is vigilance, vigilance, vigilance. And everybody's having staffing issues with anesthesia. So great to hear very different perspectives, all three of our panelists today. Well, we're approaching our end time, so I just want to wrap things up with one final question to our panelists, and that is, looking forward, what is your overall outlook for your center and looking at the ASC industry as a whole as we celebrate National ASC Month? What is your outlook for your center, and what is your outlook for the coming years with the ASC industry? And we'll start this time with Shellie.
Okay, so again, the ASC industry is evolving rapidly, becoming more and more competitive with specialized surgery centers. This attracts patients due to the highly skilled staff and improved technology to perform the surgeries. Examples being, our center has, laser assisted cataract surgery and light adjustable lens, which is like the new craze. So, again, we live in Southwest Florida, an area where there are a lot of elderly patients that require cataract procedures, making this a super competitive market. So, over the next several years, we can expect ASCs to continue to grow in popularity due to all these advances in technology and skill.
Fantastic. Colleen?
Oh gosh, I could talk for hours about this. I think
okay,
overall,
you've got a minute and a half.
Yeah. Oh, that's hard. Daren knows me. That's hard. Okay. Overall, though, I think my outlook is I'm super excited. I just am. I will always say, hands down, ASCs are where you need to have surgery. If I'm going to give my top, I think overall because it's a great place for our healthcare providers to work. It's an incredible place to have physicians to come in an efficient environment. I'm so super excited for technology advances, but I do think you have to look at return on investment always with anything new you're bringing in. Always be cognizant of that. Just because it's shiny new doesn't mean it's necessarily for your place. Make sure that you're continually looking at cost per case. You're renegotiating those contracts. I mean, again, I could go on forever. So in order to be successful, it is important to put in all of those recurrent, I guess, automated systems of things that you're looking at on a rotating basis as the administrator or the clinical operator. So.
And round us out there. She got it on time. Jeff, what's your outlook for your centers and the ASC industry as a whole?
I think one of the things is, and it comes down to the root of it, we're all individually small business people. And I think there's a turn in that we understand that we have to stay relevant and we have to reinvent ourselves and we have to keep looking what's out there. It's the funniest things is you hear of the things that just go by the wayside because you didn't stay in tune with things and move forward. And I really think the ASC industry, we're already set up to do that already. And I really, as I said, I'm very positive. I drink the ASC Kool-Aid. I really do, in the sense that I really think we're on the edge of transforming healthcare here, bringing it with technology and bringing it to more effective ways. There's an exciting initiative here in New York we're all trying to work on, is to get the approved CMS procedures in cardiac into our surgery centers. But working with the state government on that alone, we could save the state Medicaid system here in New York over $1 billion a year if those lower procedures were being able to be done in our sites. But at the same rate, there'd be access for patients to be able to get the more serious stuff done in the hospital in a more efficient and faster way. So it's an area that we really can save lives as we move forward. And it's very exciting to be part of that for the future.
Fantastic. Three very different perspectives, but all basically, coming around to the same conclusion that we're all in the growth business, and we're all striving to stay relevant. And in order to be successful in the ASC industry, we're all going to have to take that next step. And hopefully, from what you've heard from our three panelists today, you have a few ideas of how you can take your surgery center to the next step. So as we celebrate this National ASC Month, I want to thank my three panelists. Definitely a big thank you goes out to Colleen and Jeff and Shellie for joining us today and offering your perspectives.